Hello students, myself Tamilarasi, Assistant Professor in Department of Physician Assistant in School of Allied Health Sciences, VMRF-DU, Salem. Today I am going to discuss about a topic of fistula in ano. The concept should be covered in this session is anatomy of rectum and anal canal, fissure in ano, perianal abscess and fistula in ano. First we just see the overview of anatomy of rectum and anal canal. So rectum. So it is a distal portion of large intestine. It is located between the sigmoid colon above and anal canal below, in front of the last three pieces of the sacrum and coccyx. You can see this is the last three pieces of sacrum, and the rectum is just located in front of the sacrum. The upper third of the rectum is covered by peritoneum on front and sides. Middle third only on front, lower third is infraperitoneal. The rectum is pulled forward by the puborectalis muscles forming the anorectal sling, which is primarily responsible for rectal continence. It has got three lateral flexions, left, right and left from below upwards. Blood supply. The rectum is supplied by superior, middle and inferior rectal artery. The superior rectal artery is the branches of inferior mesenteric artery, and middle rectal artery, inferior rectal artery is the branches of internal iliac artery. Moving on to the venous drainage, superior rectal vein, middle rectal vein and inferior rectal vein. The lymphatic drainage. The lymphatic drainage from upper half of the rectum is to inferior mesenteric nodes, from lower half to internal iliac nodes. Nerve supply is innervated by autonomic nervous system. Sympathetic is motor to sphincter and inhibitory to musculature. Parasympathetic is motor musculature and inhibitory to sphincter. Sensation of distension is carried through parasympathetic. Pain is carried by both sympathetic and parasympathetic nervous system. Anal canal. Let's see the anal canal. So anal canal is 4 cm long. It extends from the levator ani muscle and anal verge. The denate line represents the former site of the embryonic anal membrane. The lining of the canal above this line is columnar epithelium and below is skin. The anal canal extends from levator anus muscles to the anal verge. This is the anal canal. The delate line represents the former site of the embryonic anal membrane. So this is your denate line. This is your denate line. The mucosa above this line has an autonomic nerve supply. Below is by pudendal nerve. The venous drainage above this line is by inferior mesenteric and portal circulation, whereas below to systemic venous circulation. The internal hemorrhoids can develop above this line. The venous flexes are seen here. Lot of venous flexes are seen here. This area hemorrhoids can develop. So blood supply of the anal canal, both anus and rectum, which is supplied by rectal arteries, which is superior rectal arteries, inferior rectal arteries and middle rectal arteries. Moving into the venous drainage, the internal rectal venous flexus lies in the submucosa of the anal canal. It drains mainly into the superior rectal vein but communicates freely with external flexus. It is an important site of porta systemic communication. They are situated in anal column at 3, 7 and 11 o'clock positions. Their saccular dilation forms primary internal piles. So these are the nerve flexures found in the anal canal. If these nerve flexures dilated, the patient will get hemorrhoids. Let's see the sphincters of anal canal. Anal canal has external anal sphincter muscle and internal anal sphincter muscles. The external anal sphincter, it is voluntary control. It encircles the anal canal and helps control fecus release. It has three parts: subcutaneous part, superficial part and deep part. The subcutaneous part is just under the skin. The superficial part is closer to the perineal body. The deep part is closest to the anal canal. Internal anal sphincter, smooth muscles that surrounds the upper 2/3 of the anal canal and keeps it closed to maintain continence. So these are the sphincters of anal canal. Let's see. This is internal anal sphincter and these are the external anal sphincter. The external anal sphincter is divided into three types. The one is deep and another one is superficial part and another one is subcutaneous part. Let's see the muscles of anal canal. It is a puborectalis muscle and levator ani muscle. So puborectalis muscle, part of the pelvic floor, forms a sling around the rectum to help bend the anorectal junction, aiding in continence. Levator ani muscle, pelvic floor muscles that support the anal canal and contribute to continence and pelvic region integrity. So these are the levator muscles and this is puborectalis muscle. These are the overview anatomy of the rectum and anal canal. Let's see the disease of anus and rectum. They are fissure in ano, anorectal abscess, anal fistula, hemorrhoids, perianal hematoma, proctitis, polyp, anal cancer and rectal cancer. We can see this in subsequent slides. Anal fissure. So anal fissure is a small tear in the longitudinal axis of the lower anal canal. Commonly it occurs in the midline, posteriorly, more common in males, but can also occur in middle anteriorly. In this image we can see here this is anal fissure. So there is a crack inside the anal canal and in this end we can see a bulge which is sentinel pile. There are two types of anal fissuries here, acute anal fissure and chronic anal fissure. In acute anal fissure, it is a deep tear in the lower anal skin with severe sphincteric spasm without edema or inflammation. It presents with severe pain and constipation. In chronic anal fissure, it has got inflamed indurated margin with scar tissue. Ulcers at its inferior margin is having a skin tag which is edematous, acts like a wad sentinel pile. Proximally hypertrophied anal papilla is observed. It can cause repeated infections, fibrosis, abscess formation and fistula formation. The most common complication of the fissure is perianal abscess and fistula. Chronic fissure is less painful than acute one. Multiple fissures are seen in inflammatory bowel disease, homosexuals and venereal diseases. And also because of the curvature of the sacrum and rectum, hot fecal matter while passing down causes a tear in the anal wall leading to posterior anal fissure. The anterior anal fissure is common in females due to lack of support to pelvic floors, trauma and sexually transmitted disease such as chlamydia, syphilis. Other causes are post-hemorrhoidectomy in Crohn's disease and ulcerative colitis and tuberculosis. Crohn's disease is a chronic inflammatory condition of the large intestine. In ulcerative colitis, there is ulcers that formed inside of the large intestine. Chronic constipation, chronic diarrhea, inflammatory bowel disease, passage of hard stools, anal injury, childbearing or vaginal delivery, eating low fiber diet and inflammation of the anus, scratching due to pinworm infections, excessive wiping of the anus after stool passage, rectal cancer. These are all the causes of fissure. Pathophysiology. Due to various etiology such as constipation and chronic diarrhea, the hot fecus will not completely clear. That results tear in the anal canal mucosa. That results severe anal pain, spasm of the internal sphincter, impairment of the sphincteric blood circulation. That leads to impaired healing and chronic anal fissure. The clinical features are severe pain. Pain is more severe in fissure. Also constipation, bleeding and discharge. Pain during or after going to the toilet which might last for several hours, cramping around the anus. Blood on the stool or toilet paper after wiping the bottom. Itchiness around the anus, a small crack or tear in the skin around the anus. During rectal examination, proctoscopy is contraindicated. The proctoscopy can injure the fissure more. In chronic fissure, ulcer is felt with a button-like depression, induration and often sentinel pile. So this is the sentinel pile. So investigations, first we have to collect the detailed history of the patient, whether the patient has constipation or diarrhea or any other inflammatory conditions of the large intestine. Then we have to do physical examination. Per rectal examination, patient have to lie down on the Sims position. We have to check the patient's anal area. A small tear with redness will be present and also a skin tag will be present in chronic fissure. Proctoscopy and sigmoidoscopy is contraindicated in fissure while examining because the proctoscopy can injure the fissure area more. The proctoscopy can be done under anesthesia. In chronic fissure, CBC and screening of the tuberculosis and HPA also required. General measures for the anal fissure: adequate fluid intake, around 6 to 8 glasses of liquids, fiber-rich diet, vegetables, fruits, brown rices, bulk forming agents, xylem husk bran, stool softeners, local anesthetic agents, lignocines, sitz bath. We have to give sitz bath with betadine solution 2%, avoid constipation, and once recovers, regular anal dilation. The treatment are, in acute case, stretching of the anal sphincter. So, using 2 fingers of each hand, 4 fingers under anesthesia is also alternative one. It is better than Lord's dilation as complications are less. We see the Lord's dilation in subsequent slides. So, this is the stretching of the anal sphincter using 2 hands. In Lord's dilation, both hands are used, 4 fingers from each hands used to dilate the anal canal. It is done under general anesthesia or spinal anesthesia. Later, we have to give laxatives and xylocaine for local application. After the procedure, the patient have to take bed rest and we can give 2% nifedipine ointment. For chronic fissure, dorsal fissurectomy with sphincterectomy and lateral anal sphincterectomy. We have to cut the sphincter muscles. Here we have to cut the sphincter muscles and also remove the sentinel pile. So, this is lithotomy position. The complication of fissure are infections, bleeding, pain, incontinence, formation of fistula and anal stenosis. So, infections, chronic fissure may lead to the abscess formation. Bleeding, anal fissure hurts and may cause bleeding during stool passage. In pain, the pain exposure of the external sphincter muscle under a tear leads to spasm and pain. In chronic anal fissure patients, the function of the internal sphincter is altered due to hypertonia and may cause a minor degree of incontinence and also results perianal fistula. Later, if the patient have fissure, the anal area get inflamed and get swelled. So, results anal stenosis will happen. Moving on to the perianal abscess, this usually results due to suppuration of anal glands or suppuration of thrombosed external pile or any infected perianal condition. It lies in the region of the subcutaneous portion of external sphincter. We can see this is submucosal abscess, this is pelvic rectal abscess, this is ischiorectal abscess, this is perianal abscess. So, this is anal area, so nearly perianal abscess present. The causes are infected anal gland and fissure, inflammatory conditions such as Crohn's disease, rectal trauma, bacterial infections, poor hygiene. The infected anal gland blockage leads to infection and abscess formation. The fissure can cause infection and inflammation in the anal area that results bacteria grow inside the anus that causes abscess formations in the perianal area. The Crohn's disease, it is a chronic inflammatory conditions as I already told. The rectal trauma, any road traffic accident or any injury or post hemorrhoid surgery, the patient will have perianal abscess if the patient is not maintain good hygiene or skip the antibiotics. The bacterial infection, most common bacteria is Staphylococcus aureus. Poor hygiene, if a patient having fissure or perianal abscess or hemorrhoids, any cases, any conditions, if patient is poor hygienic, the patient will develop perianal abscess. The clinical features are severe pain in the perianal region with difficulty to sit, tenderness, smooth soft swelling in the region and fever. The investigations methods are physical examination, have to check the perianal area. So, the anal area get swelled and also if we touch the temperature will high. Imaging test are ultrasound, MRI. Ultrasound we have to check the size and location of the abscess. In MRI and CT for deep or complex abscesses. Microbial testing, pus samples can be taken to identify the bacteria for targeted treatment. Endoscopy is optional if other conditions such as Crohn's disease or any problem inside the large intestines. The treatment are sitz bath, antibiotics and analgesics. Sitz bath we can give fissure and perianal abscess. Any anal surgeries we can give sitz bath. Sitz bath is nothing but we have to put povidone iodine solution inside a basin with hot water. The patient have to sit on the basin. The microorganism will killed. Antibiotics we can give injection piperacillin or injection cefobirazone sulbactam IV. Analgesics we can give tramadol. Local application of the anesthetic agents, laxatives, incision and drainage under anesthesia, under spinal anesthesia. So this is a cruciate incision done for perianal abscess. The complication of perianal abscess is anal fistula, recurrent abscess, sepsis, ongoing pain, tissue damage and narrowing of the anus. So anal fistula is followed by the perianal abscess. If the abscess will drain, there is a small gap present inside the anus that results anal fistula. Recurrent abscess also happen followed by the infections. Sepsis, the bacteria enter into the circulation in sepsis and patient having severe pain while perianal abscess. Tissues also damaged in rectal area and anal area followed by the perianal abscess, and also narrowing of the anus followed by the swelling inside the anum. Let's moving into the fistula in ano. Fistula is an abnormal tract or communication in the anal canal and sphincteric muscles, and also anus. It usually occurs in pre-existing anorectal abscess which burst spontaneously. Anal crypts refers to small glandular structure located within the lining of the anal canal. Fistula can be cryptoglandular or non-cryptoglandular. It can occur both blockage of the anal crypts or other than anal crypt blockage. It can happen inflammatory conditions. The classifications are Parkes classifications: intersphincteric fistula, transsphincteric fistula, supra-elevator or supra-sphincteric fistula, extrasphincteric fistula. So these are the classification. This is intersphincteric fistula and this is transsphincteric fistula, and this is elevator ani muscle. So this is supra-elevator fistula, and this is extrasphincteric fistula. This is referred as high level fistula. Standard classification are subcutaneous fistula, submucous fistula, low anal fistula, high anal fistula, pelvic rectal fistula. So the etiology are cryptoglandular causes. Cryptoglandular means the crypts will affected or the crypt duct will get blocked. So that is anal rectal abscess, perianal abscess. Non-cryptoglandular causes are tuberculosis, diabetes, Crohn's disease, ulcerative colitis, foreign body obstruction and carcinoma rectum or anus. The pathophysiology are anal canal which secrete mucus for proper excretion of waste. Due to blockage of anal glands duct, decreased mucus in anus. Fecal matter doesn't excrete properly. Infection may occur. Results inflammation of the anal area. Anorectal abscess or perianal abscess progress into the muscular valve of anal sphincter. Results fistula in ano. And also anorectal abscess gets ruptured. After that, induration of the abscess to form a tract. It is a blind end tract. Results fistula in ano. The clinical features are seropurulent discharge with skin irritation, pain in anal area, redness, pain during defecation, fever. One or more opening may present with or without induration of skin. Often it may heal superficially, but pus may collect beneath forming an abscess which again discharge through same or new opening. Let's see the Goodsell's rule. Most of fistula found in posterior half of anus, curved tract. Anterior fistula have a straight tract. So this is anterior fistula and this is posterior fistula. The investigations are history collections and physical examination. In physical examination, we have to inspect the rectal area. There is a small bulge or swelling present, and also a small pinpoint pus discharge also present, and also palpations. If we palpate the rectal area or anal area, the patient will get severe pain. So next, temperature is high. If we touch the anal area, the temperature is high, and laboratory findings are culture sensitivity, stool examination to rule out the microorganism, whether Staphylococcus or Streptococcus, any other bacteria. The imaging techniques are barium enema X-ray, MR fistulogram, methylene blue dye study, endorectal ultrasound and transperineal scan. So this is endorectal ultrasound. We can see the fistula here. And other investigations, barium enema study, colonoscopy if necessary, and biopsy. Biopsy for chronic perianal abscess with fistula. The treatment goals are prevent further induration, avoid infections, symptomatic relief, prevent recurrent fistula. The medical management are to prevent further induration, incision and drainage of the perianal abscess or anorectal abscess, avoid infections. So incision and drainage of the abscess is surgical management. We have to medically manage by giving antibiotics, painkillers. The antibiotics are cefovarazone sulbactam 1.5 gram IV BD, injection metronidazole 500 mg IV TDS. We can give piperazolone also. For symptomatic relief, we have to give analgesics such as ketorolac, injection tramadol. If a patient having fever, we have to give antipyretic agents such as paracetamol. Medical management of anal fistula are fistulectomy, fistulotomy, gluing of fistulous tract, lift, which means ligation of intersphincteric fistulous tract, waft procedure, fistula clip closure. We can see this in subsequent slides. Fistulectomy, all chronic fistula are treated by fistulectomy by excising the entire fibrous tissue and tract. Here also the wound is kept open. This can also be done for posterior semi-horseshoe and horseshoe fistula. Fistulotomy, it is indicated in low fistula. A probe is passed through the external opening into the rectum, and along the length of this tract the fistula is laid open. It is done under either spinal anesthesia or general anesthesia. The wound is left open and allowed to heal by granulation tissue developing from the floor of the fistula. Intersphincteric and low transsphincteric fistula of recent origin are treated by fistulotomy or marsupialization. Gluing of the fistula. So fibrin glue is multi-component system containing mainly human plasma fibrinogen and thrombin. We have to fill the fistulous tract by this fibrin glue. Once prepared it is injected into the fistulous tract, which hardens in few minutes and fills the entire tract. The success rate is 70%. Anal fistula plug repair. So surgery is anal fistula plug is used with 80% of success rate in simple fistula. It contains naturally derived extracellular matrix which acts on scaffolding in growth of tissue remodeling. Lift technique, which means ligation of intersphincteric fistulous tract. Under general anesthesia in lithotomy position, intersphincteric space is reached through a transverse incision. Fistula running across is identified and ligated using vicryl on either side. Part is excised, outer part is curated through external opening. Waft procedures. It is also like lift procedure. We can use video assisted device for treat the fistula. So fine specialized endoscope is passed through the outer opening into the fistulous tract. With continuous irrigation, fistula tract is cleaned and wall is cauterized. Inner opening is ligated through vicryl from luminal side. Fistula clip closure. Closure of the internal fistula opening with a super elastic clip made of ninitol by German surgeon Rutger Frost. High level fistula. Abnormal opening at above the level of anorectal ring. It is difficult to treat. Common causes are Crohn's disease, trauma, carcinoma and foreign body such as copper T. If a patient have chronic fistula, chronic recurrent fistula, we have to give colostomy. Colostomy is nothing but we have to put colon outside the abdominal wall and put a bag. In high level fistula, we have to initiate the colostomy. It promotes faster healing. Later the closure of the colostomy will be done. In colostomy, we have to put one bag outside the colon and we have to put the colon outside the abdominal wall. So this is colostomy bag. And another surgical option is set-on technique. A silk or linen ligature is passed across the fistula, left in the place with tie. Straightened muscles superficial to fistula tract is encircled with seton material and tied, which is left in situ. Seton can be kept for 3 months. It can be tight or loose seton depending on the indication. So this is the seton. There are two types of setons are present, loosened seton or cutting seton. Loosened seton are used mainly to drain for long period in recurrent or post-operative fistula. Cutting seton are used when enclosed muscles is needed to cut. It is places tight. So this is loosened seton. The complications are inflammatory bowel disease, recurrent fistula, pelvic inflammatory disease, urinary tract infections, proctitis, sepsis and bleeding. Thank you.